Good morning, good afternoon, and good evening, my friends, depending on your location. We welcome you all to TCT Highlight. This is part one of 3 sessions we'll be doing to review TCT meeting. No way I will be able to summarize all TCT meeting in an hour. Lots of good abstract. We'll try to provide you pertinent brief information on selected clinical abstract. Today we are going to review AML, ALL, MDS, MPD, and conditioning regimen. I have no conflict of interest to declare. We'll start with this very important clinical abstract presented by our friend Dr. Poppert from MD Anderson, myeloablative fractionated busulfine conditioning regimen in older patients, a result of phase 2 study. This is one of the 3 best clinical abstracts presented at the meeting. Main idea in study is you can reduce the toxicity and attendant mortality of intense regimen by simply giving it over a long period of time. Slide summarizes the author's prior experience of using their first generation fractionated busulfan regimen, time sequential regimen. Regimen details summarized here. Outpatient busulfan was started on day -13 with PK study. Second PK study was performed on day 6 and total busulfan dose calculated to achieve AUC of 20,000. This is equivalent to average AUC achieved in myeloablative dose of busulfan, and what was designed by Professor Dr. Borji Anderson, one of our friends at MD Anderson. Standard GVHD prophylaxis was used, FK and mini-methotrexate. And this was the outcome using their first generation fractionated regimen. I also call it a sequential regimen. Safe, non-relapse mortality was 6% at 100 days, 22% non-relapse mortality at 1 year in older patients. Promising efficacy. Studies results were published in Lancet Hematology a couple of years ago. And this is their next generation fractionated busulfan conditioning regimen in older patients presented at the meeting. Authors hypothesized that even longer administration of busulfan, last time they did on day -13 and now day -20. But with main other changes, what instead of doing FK mini-methotrexate, they changed GVHD prophylaxis to post-transplant cyclophosphamide combination. Looks like everyone wants to change GVHD prophylaxis to PTCY-based regimen. Conditioning chemotherapy started on day -20 as an outpatient with PK study. Busulfan AUC was around 220,000, which is equivalent to busulfan ablative dose. According to authors, it was more intense if we do calculation by AUC than patient receiving BUSI regimen. Standard eligibility criteria, 78 patients were enrolled between July 2017 to July 2019, very recent cohort. More than half of the patients were above the age of 61-year age. Majority of patients were MDS, MPD, and mostly high or very high group categories highlighted here. 40+% of patients had a transplant comorbidity index of 3 or higher. No graft failure reported in the series. Decent time to engraftment and full donor chimerism by day 30 in almost all patients. Slide summarizes the toxicity and GVHD data. Not bad, right? Remember, this regimen is more intense compared to BUSI, and median age of cohort was 61 years. That means more than half of the patients were 60 plus. Severe acute GVHD rate was only 5% at day 100, and chronic GVHD at 1 year was only 9%. Impressive outcome graph. You can see here, 1 year survival, 95%, Non-relapse mortality at 1 year, only 4%. Let me remind you again, this is an older age patient, median age 61 year. Outcome by disease risk index, which is how most people report now. Impressive outcome, even in patient with high or very high DRI. You can look at here, low intermediate risk, 95% 1 year, 2 year survival. And in patient with very high or high DRI, 46% 2 year survival. Very impressive. No difference in outcome between age above 60 and below. Very impressive. Study regimen help older adults to behave like younger counterpart. Again, Dr. Soror's transplant comorbidity index did not have any impact on outcome. Impressive outcome in patient with score 3 or more. Remember, nearly 50% of patients in this cohort were 3 or more comorbidity index. Slide summarizes the outcome by disease types. If you remember, most patients in the study were MPD, MDS, and mostly high-risk group category. This regimen worked best in this group of patients. 2 year survival, 91% and 85% respectively. I don't think I need to read this slide. Question is, can you further reduce the relapse risk, especially in patients with very high DRI? Probably yes. Maybe to add other agent to this backbone, maybe thiotepa or other drug, and possibly to consider post-transplantation maintenance. And this is another nice abstract. Phase 3 study in FLT3 ITD mutated relapsed refractory AML undergoing transplantation after quizartinib or salvage chemotherapy in QuANTUM-R trial. Now, let me inform you, the major or first part of this study was presented as an oral presentation in last ASH meeting, December 2019. And I'm going to review transplant section of this phase 3 study. As we all know, patients with FLT3 positive relapsed refractory AML have a poor clinical outcome and limited effective treatment option. In the phase 3 QuANTUM trial, quizartinib, difficult to pronounce for me, highly potent selective FLT3 inhibitor showed improved survival compared to investigator's choice salvage chemotherapy in relapsed refractory FLT3 positive AML. In this study, author reports post hoc analysis in patients who underwent subsequent allotransplantation in this trial, meaning how much investigational drug quizartinib helped to increase the number of transplantation versus standard salvage chemotherapy and their outcome in patients with relapsed refractory acute myeloid leukemia. I'm checking screen is working. Okay, so this was a randomized study, phase 3 study, as you know, 2-to-1 randomization. There were 245 patients in the investigational drug arm and 122 patients in salvage chemotherapy group. 78 patients in the investigational arm received allotransplantation in the quizartinib group without additional AML therapy, meaning a patient had a relapsed refractory AML with previous standard treatment, and they received either quizartinib versus salvage chemotherapy. Out of 245 patients, 78 patients with single investigational agents were able to receive transplantation versus only 14 patients in an investigator's choice salvage chemotherapy group. Regimen could be MAC, FLAG-IDA, venetoclax-based regimen, or low-dose IRAC. Slide summarizes cumulative incidence of transplantation over time. Way more patients in investigational arm able to receive allotransplantation compared to salvage chemotherapy group, which include patients receiving MAC, FLAG-IDA, or any other combination. And remember, These are all refractory, relapsed refractory FLT3 AML, and goal is to get them eligible for curative transplant procedure. If more patients receive transplant, more we cure them, right? And this is what we have here. Answer is yes. You can see here 1 year survival, 50% in relapsed refractory AML if patient had transplantation versus only 13% who were not able to receive transplantation. In conclusion, more patients treated with quizartinib underwent allotransplantation, 32% versus 11%, likely due to higher rate of CR, longer CR, and less early mortality before transplantation with investigational drug versus standard salvage chemotherapy. And pool analysis demonstrated longer survival in patients with allotransplantation versus without. This is acute leukemia working party study, excellent paper. Allogenic transplantation for AML patient with RUNX1 mutation in first complete remission. I presented this abstract on behalf of Johanna, my colleague at Acute Leukemia Working Party. Prognostic value of RUNX1 mutation in AML and MDS is well known. I don't need to summarize. Data suggested presence of RUNX1 mutation indicates higher rate of chemotherapy resistance and inferior outcome, and this is one of the best JCO study, leukemia studies summarized here. Slide reviews the well-known 2017 ELN risk stratifications by genetics. RUNX1 mutation is considered adverse risk category by ELN risk stratification by genetics. And this is important study. Now in reference to transplant outcome in patient with RUNX1 mutation. Fairly large study, included 401 patients underwent allotransplantation in patient with MDS and secondary AML. RUNX1 mutation was most frequently mutated gene in about 23% of patients, AXL1 in 17%, and TP53 in 13%. The impact of RUNX1 mutation, in addition to AXL1, TP53, on post-transplant survival was independent of revised IPSS MDS testing. That means they are worst group of patients. Now, very limited data in patients with RUNX1 mutation in de novo AML in CR1 undergoing allotransplantation. There are some summarized here. We can't make any conclusion from this summarized series, small subgroup analysis. Bottom line, no large series reporting role of RUNX1 mutation in allotransplant outcome in patients with de novo AML in CR1. To answer this question from large database, Acute Leukemia Working Party of EBMT perform a registry analysis. Slide highlights the study population. Endpoints were major transplant outcome parameters, and standard statistical methods were used to analyze large registry database by our famous statistician, Professor Bipin. I call her statistician on call. You send the query and next day, within few hours, you have the reply, including graph or new analysis. Total 516 patients with AML and CR1 included in this analysis, with complete information on conventional cytogenetics and RUNX1 mutational status at the diagnosis in all patients. Almost 450 patients with de novo AML in CR1. Slide highlights the study population and distribution of patients between the group. Both groups were well balanced, except, and as expected, there was imbalance with respect to good guys loving the good guy and bad attracted toward the bad guys. NPM1 considered good. They didn't like the RUNX1 bad guy. AXL1, bad mutation again. Like RUNX1, 50% of patients had positive RUNX1 in AXL group. Slide summarizes the long-term outcome after allotransplant in both groups. Decent overall outcome as expected in patients receiving allotransplant in CR1. but no difference in any outcome parameter between the RUNX1 mutation and negative group. Now, authors were interested in analyzing in patients with normal karyotype. Again, no difference in leukemia survival between the group, higher overall survival in RUNX1 positive group after allotransplant in enumerate analysis. Slide summarizes outcome in patient with de novo 450 patient, de novo AML with RUNX1 negative and positive group. Again, no difference in outcome between the group. However, 2-year survival was 78% on RUNX1 positive group after transplantation in CR1. There was trend towards superior survival. And this is adjusted multivariate analysis. There was no statistically significant association between RUNX1 mutation status and any clinical outcome in CR1. Factor independently associated with outcome summarized here, and common variables were impacting outcome. In conclusion, the unfavorable prognostic value of RUNX1 mutation on outcome of de novo AML patient might be overcome by transplantation in CR1. We can also say that there is a different relevance of RUNX1 mutation in de novo AML compared to mutational positivity in MDS and secondary AML. Clearly inferior outcome of RUNX1 mutation patient transplanted for secondary AML or MDS with 2-year survival 47%, which we reviewed earlier, as compared to RUNX1 mutation patient in de novo AML, 2-year survival 78%, which I presented. Some limitation, missing data of AXL1, and perhaps MRD status might explain the somewhat superior outcome in patient bearing the RUNX1 mutation in this study, and this work is in progress. It's very important abstract again, outcome in patient with AML with MRC, myelodysplasia related changes, who achieved remission with CAPX351 versus standard 7+3 induction. This was a phase 3 exploratory analysis presentation. AML, MRC patients typically have poor prognosis, and I don't think we need to go into the details. CPX351, also known as Vyxeos, a dual drug liposomal encapsulation of cytarabine and daunorubicin at synergistic ratio 100 per milligram per meter square cytarabine, and I think 44 milligram per meter square daunorubicin. Drug Vyxeos is approved by FDA and EMA for treatment of patient adult AML with MRC or secondary acute myeloid leukemia. Based on this phase 3 study listed here, superior survival with Vyxeos versus standard 7+3. In this exploratory analysis, subgroup analysis, phase 3 study, author compared the outcome of patient with AML MRC who achieved CR or CRI with incomplete recovery. Patients were randomized 1:1 to receive 1 to 2 induction cycles with Vyxeos, CPX351 or 7+3. Patient achieving CR or CRI could receive up to 2 consolidation cycles with CPX351 or 5+2. Patient could receive transplantation at the physician discretion. 246 patients, 123 patients in each arm. More AML MRC patients achieved CR plus CRI with Vyxeos, 48% versus 33% in 7+3 arm. Transplant rate, that's what our most important point. Transplant rate in ML MRC patient with CR plus CRI was 54% versus 43% with 7+3. Bottom line message here is more patients achieved remission with CPX351 group, and therefore transplant rate was higher in CPX or Vyxeos group. And therefore overall survival landmark from transplant date was longer in patient receiving Vyxeos. Similar to abstract 7 which we reviewed, quizartinib FLT3 inhibitor. Once patient received transplant, outcome is better than non-transplant group. Again, important message is how to increase number of patients eligible for transplantation in patients with relapsed refractory acute myeloid leukemia. As we all know, this is an important extract again. MLL, KMT2A is considered intermediate risk category, genetic abnormality in 2017, ELN risk classification by genetics. But many of us don't agree with this, right? I believe MLL or 1123, it is as bad as adverse risk cytogenetic groups. And this is what investigator authors try to study in this abstract. To answer this question, this is the analysis was performed 2000, nearly, let's see here, nearly 4,000 patients, all AML in CR1. 11q23 rearrangement partners are summarized here. Most common partners were translocation 911 and translocation 1119. I skipped the univariate analysis, and this is multivariate analysis. I'll show you adjusted graph in a minute. Overall survival was shorter for MLL or 1123 group, and also adverse cytogenetic risk group as expected. Now, important finding was no specific 11q23 arrangement or MLL partners were better than other partner. All were same. And this is a nice graph, adjusted DFS and overall survival by all three groups. You can see here, best outcome for patient with intermediate cytogenetic risk group, and inferior outcome, overall survival, in patient with adverse cytogenetic group, and also with MLL rearrangement. Again, non-relapse mortality was no different between all three groups, and relapse risk was highest in patient with adverse cytogenetic risk group, followed by MLL, and lowest in patient with intermediate cytogenetic risk group. In conclusion, MLL, rearranged AML had post-transplant outcome were more or similar to patient with adverse risk cytogenetic group compared to intermediate risk cytogenetic group. Studies suggest that patients with MLL rearrangement do almost as poorly as those with adverse risk group, and that novel approach for this high-risk population represent an urgent unmet need. And this is one of my favorite presentation. As you all know, initial report of this study, BMT-CTN 0901, was published in JCO in 2017. And now we have a long-term follow-up of BMT-CTN 0901. It was a randomized phase 3 trial comparing reduced intensity versus ablative regimen for AML and MDS. Those who don't know about previously published BMT-CTN 0901 data, this is background information. Study compared reduced intensity regimen versus ablative in patients with AML or MDS who had less than 5% blast pre-transplant. Most commonly used regimen were flu-bu, 2 days, reduced intensity, flu-bu, 4 days, myeloablative regimen. I was medical monitor on this BMT-CTN study. Author presented long-term follow-up of this study at TCT meeting, median follow-up of 50 months. As expected, more the better. Overall survival at 4 years was 65% after myeloablative conditioning regimen versus 49% after reduced intensity. Similarly, superior relapse-free survival statistically highly significant in favor of ablative conditioning regimen. Nice, highly separated curve showing superiority of ablative regimen in all aspects. This trial reconfirmed the importance of intensity for transplantation for patient and ablative regimen with superior choice, and to consider ablative regimen when possible. Now, impact of genetic mutation on outcome of allotransplantation in patient with AML with antecedent MPD is not well known, not much described, many limited literature. And it's interesting and very important question, right? And this is a very nice study presented from the CIBMTR. We at Acute Leukemia Working Party EBMT and others have previously demonstrated that poor outcome for patients with AML with antecedent MPN undergoing allotransplantation. Best example is myelofibrosis patient transformed into AML, poor outcome after transplantation. Now, author in this study hypothesized that genetic mutation may predict the efficacy of transplantation in molecularly defined subgroup of post-transplant, post-MPN AML, transformed acute myeloid leukemia. Patient considered in remission at the time of transplantation may have a similar molecular profile to those who have acute leukemia at the time of transplantation. Very interesting hypothesis. 177 patients with post-MPN AML, transform AML, identified in CIBMTR database. 95 patients had sufficient DNA to perform next generation sequencing, NGS. Most frequently mutated in genes in this cohort were JAK2, 55%, as expected, as these are all transformed MPN patients. JAK2 is very common. Other common mutated genes were TP53, 23%, AXL1, 22%, TET2, 91%, 19%, and RUNX1 in about 14%. Poor outcome, as we expected. Overall, as expected, very high risk group patient with AML transformed from prior MPN. 5-year progression survival, progression-free survival only 11%, and 5-year survival 16%. In a multivariate analysis, TP53 mutation status was the only factor associated with outcome, inferior transplant outcome. Most importantly, disease status at the transplantation was not associated with outcome. We always try to bring the blast down before going into transplantation. Here, it looks like it doesn't work. More chemotherapy we give, try to bring down the blast percentage. We are going to increase more non-relapse mortality without any benefit. And that's what we can say here. Now, this is TP53 survival. You can see here, nice Kaplan-Meier survival curve in patient with and without TP53. In conclusion, we can say here there is a minimal benefit of transplantation in patient with post-MPN AML with mutated TP53. Novel strategies are required in this patient, and I think there is ongoing clinical trial by Eprin Pharmaceuticals, maybe APR-246 Prima 1 MET drug hopefully will get approval, FDA approval soon. Expected to complete phase 3 clinical trial later this year. Not sure now with COVID-19 because most programs have halted clinical trial activities and new enrollment, including at our program, new enrollment in a clinical trial is on hold. And this was one of my favorite abstracts too. Targeted conditioning with anti-CD45 iodine, apamistamab, I will call it IOMAB-B, leads to high rate of allotransplantation and successful engraftment in older patients with active relapsed refractory AML after failure of standard chemotherapy. And this is a very good phase 3 clinical trial data they presented. Main message in this abstract is how to increase or facilitate more patients eligible for transplantation in patients with relapsed refractory AML. More patients we make them eligible for transplantation, more we can cure them. This is more or less similar to abstract we discussed before on FLT3 inhibitor quizartinib and Vyxeos CPX351. Now this product, IOMAB-B, originally was developed at the Fred Hutch in Seattle. As we all know, among old adults with relapsed refractory AML, less than 20%, this is again generous number, less than 20% patients able to receive transplantation. Most patients die from progressive disease before we can make them eligible for transplantation. This Sierra trial is a prospective randomized phase 3 trial addressing the unmet need to improve the access of allotransplantation in old patients with active relapsed refractory acute myeloid leukemia. Patients were randomized 1-to-1 to receive IOMAB on day -12, followed by flu-TBI, it's a reduced intensity or non-ablative Seattle regimen, and transplantation, or to conventional care arm. Conventional care patient may receive investigator choice of salvage therapy, MAC, Flagida, venetoclax-based regimen, hypomethylating regimen, whatever combination they want to make it. If patients do not achieve remission with conventional care, study allows crossover to IOMAB transplant arm. Preliminary data are available from 75 patients, it's 50% of population. Median age, again, remember, 64-year-old cohort, heavily pretreated. Circulating blast, median blast percentage around 30%. All transplanted patients after IOMAB-B and grafted. Conventional care arm, they did poorly as expected. 31 of 38 patients in conventional care arm failed salvage chemotherapy. 7 patients get remission. Out of these 31 patients who failed the conventional care, 22 patients that cross over to IOMAB, 20 were able to receive transplantation, despite median of 35% blast. That means 31 patients on IOMAB transplant arm plus 20 from the conventional care arm received transplantation. So total 51 patients received IOMAB and transplantation. IOMAB administration was generally well tolerated with 1 grade 3 toxicity and no grade 4 infusion reaction. All patients transplanted and grafted, and there was no IOMAB related death. 100-day non-relapse, which TRM was only 3% on IOMAB arm. In conclusion, the author did not present any outcome data. Despite advanced age, active disease, heavily treated, all 31 of 31 patients on IOMAB were able to receive transplantation successfully and grafted, and compared to only 18% in the conventional care group. Overall, including patient crossing over to receive IOMAB-B transplant after failing conventional care, 68%, 51 of 75 of all patients enrolled in a clinical trial underwent transplantation. Again, this is a preliminary results, represent significant improvement in the current rate of transplantation in this worst group of patient population. This Sierra trial is currently enrolling. It is expected that phase 3 trial will be completed. Initially, it was planned to complete by mid-2020 this year, but it will be delayed again due to COVID-19 and poor enrollment expected because most centers have shut down the new enrollment. This is a very hot topic, right? Great abstract, cytokine release syndrome after haplo-transplantation. Very nice study. Now, use of haplo-transplantation will continue to increase. We all know that, and I'm not going to go into details. However, the main point is peripheral blood haplo-transplantation has its own unique problem and complication, right? Including cytokine release syndrome and many others, viral infection and many things. We are going to focus on CRS today. So what happens in CRS? massive elevation in cytokine level. You can see here several fold increase in level of after cell infusion. As we all know, CRA has been reported after CAR T cell and other cellular and immunotherapy, of course, with haplo-transplant. Now, cytokine profile have been described, and it's unlike those reported in both acute GVHD and engraftment syndrome. So it's not similar pattern. You can see here in this slide. Slide shows prior publication from the author. Severe CRS affects 16% of patients in this study published in BBMT 2016, and severe CRS was associated with dismal outcome, and we all know that. CRS risk factor after haplo-transplant summarized here from the literature. Based on published data and also on our experience, very likely risk factor include peripheral blood stem cell graft, haplo, and active disease at transplantation. And it's also very important to avoid confusion. It's very important that we know that unlikely to be risk CRS factors are age. Age has no impact based on most published data. Ablative regimen or RIC regimen has no impact on CRS based on unlikely to be factor. Similarly, sex mismatch and ABA mismatch unlikely to be a risk factor for CRS. The objective of this study was to determine the risk factor and effect of CRS on haplo-transplant outcome. Retrospective analysis, including all patients who underwent haplo-transplant at 4 academic centers between 2009 and 2018. Standard definition and statistical methods were used to analyze this large database. 451 patients were included in this analysis from 4 academic centers listed here. Majority of patients came from WashU. You can see here, Italy, Medical College of Wisconsin, and some patients from Pablo in Colombia. So in this cohort, 10% of patients had no CR. So that means 90% patients had a CRS. Of this, 7% had a severe grade 3 to 5 CR. 17% had a severe CRS. This was consistent with published report. Patients receiving peripheral graft had high incidence of severe CRS than those receiving bone marrow, 20% versus 5%. Factors not associated with CRS grade include patient's age, donor recipient gender pairing, and myeloablative conditioning regimen. Factors which are associated with CRS grade included stem cell source, peripheral versus bone marrow, presence of active disease risk index, active disease, transplant comorbidity score, CMV positivity in donor. Not all these characteristics were associated with high-grade CRS, and there was limitation here. This analysis does not tell the direction, but we know which direction would be higher CRS. Time to neutrophil and platelet graft were both significantly longer in patients with CRS, severe CRS. There was no difference in acute GVHD or severe acute GVHD between the CRS group. There was a significantly lower incidence of chronic GVHD in patients with CRS with hazard ratio of 0.2. Non-relapse mortality was similar in patients with no CRS and those with mild CRS and was under 20% in both groups. However, as expected, NRM was significantly higher in patients with severe CRS with hazard ratio of 7.1, very, very high, and much higher incidence of early death after transplantation. You can see here almost 40% NRM at day 100. The relapse was lower in both mild and severe CRS group. Consistent with previous report, severe CRS was associated with worse overall survival, with hazard ratio of death more than 2, meaning group with severe CRS has twice the chances of dying than comparison group. Here, no CRS group. In summary, this large study showed that severe CRS is 4 times more likely with T-cell replete peripheral haplograph. Severe CRS is associated with poor survival, mainly driven by the non-relapse mortality, mostly very early death. Mild grade 1 to CRS is associated with improved survival, driven by mainly reduction in relapse. This is again very nice abstract. Sorry. Comparison of matched sibling, match unrelated, and haploidentical donor transplant using post-transplant cyclophosphamide in patient with AML in CR1. This is also acute leukemia working party study. Interesting and important large series in the absence of large randomized data at present. As we all know, PTCY after haplo-transplantation is very effective in preventing GVHD. We all know that, right? However, there is not enough information on impact of GVHD prophylaxis with PTCY in matched sibling donor transplant and match unrelated donor transplant. And this is a goal of this study, to compare transplant outcome of matched sibling donor, match unrelated donor, and haplo-transplant. All 3 group sources received PTCY-based GVHD prophylaxis. This is a registered study on behalf of Acute Leukemia Working Party. All patients were in AML in first complete remission. Haplo patients were older than match-related and match-unrelated groups. Significantly higher proportion of patients with secondary acute myeloid leukemia in haplo group. More patients received ablative regimen and bone marrow graft in haplo group compared to patients in match-related and match-unrelated group. Majority of patients received PTCY-based prophylaxis, GVHD prophylaxis in haplo group, mainly calcineurin inhibitor and MMF, as you know. And this is multivariate analysis. I skipped the univariate analysis. Grade 2 to 4 GVHD was higher in haplo group. However, severe acute GVHD was no different between the group. Similar NRM was independently associated with haplograph, higher NRM in haplogroup with hazard ratio of 2.6. Good news, it was associated with relapse, was less relapse in haplogroup, more HLA disparity, maybe more alloreactivity, and decreased relapse. Bottom line, no difference in leukemia-free survival, overall survival, GRFS between all 3 groups. Nice overlapping curves you can see here, leukemia-free survival and overall survival between all 3 groups. Author concluded that no difference in outcome between all these 3 groups in AML CR1. HLA mismatch in haplo has a negative impact on acute GVHD and NRF, but offer increased anti-leukemia activity by decreasing leukemia relapse rates. As seen in other transplant scenario, peripheral blood is associated with more GVHD and less relapse. MEC ablative regimen offers improved survival in this setting. And this is a very interesting study. Although this was a very small series, but I like this study because it offers calcineurin-free haplo-PBSCT, and we can probably use this regimen in patients with pre-existing mild or moderate renal insufficiency, or in patients who are at risk of renal complication. But this is a prospective study. We all know that PTCY is effective in preventing GVHD after haplo-transplant. Recent CIBMTR study led by our friend Dr. Bashi We compared peripheral blood versus bone marrow haplo-transplant with identical PTCY-based GVHD prophylaxis. Data showed peripheral blood reduced the risk of relapse but increased the acute GVHD. However, overall survival was similar between the group. And that's bring to the hypothesis of this study. The author hypothesized that Sirolimus in combination with PTCY, post-transplant cyclophosphamide, and MMF as a calcineurin-free GVHD prophylaxis will reduce the risk of acute GVHD despite using peripheral blood haplograph. Authors were interested in standard transplant outcome measures. With 32 patients, evaluable patient enrolled, study had 90% power to demonstrate a reduction in 100-day acute GVHD from their historical benchmark of 40% to 20%. Please remember this 20% acute GVHD goal number. Standard inclusion criteria. All patients were enrolled in 18 months between 2017 and 18, very recent cohort. Ablative regimen with busulfan based regimen, targeted AUC of 5,300. Presence of donor-specific antibody DSA was exclusion criteria to avoid any confusion regarding graftment. Patient characteristics summarized here, nothing unusual. And same here, nothing unusual. 2/3 of the patient received ablative regimen, all busulfan based. Median peripheral blood CD34 cell dose was 7.19. This is quite higher than we use in our program. For our program, we cap at 5 million per kilogram if we are using peripheral graft to decrease the risk of CRS in haplo setting only. Almost all patients had a decent full donor chimerism at day 30 in this study. Importantly, not a single patient developed severe CRS, unlike large haplo series we saw reviewed just recently with 17% severe CRS. This is a very good cohort. All patients engrafted. Day 100 acute GVHD rate was less than 20%. So they made what they designed for the study. Less than 10% patient developed severe acute GVHD. Combined moderate plus severe chronic GVHD rate was 20% at 1 year. But think this, only 3 patients required systemic steroid for chronic GVHD, and rest responded to reinitiation or increase in Sirolimus dose. 1 year NRM was 20%, not bad. And 1 year overall survival 70% as expected, considering almost 50% patient with high risk disease category. So impressive data using PTCY with Sirolimus haplo PBSCT, most importantly, without using calcineurin inhibitor. I don't know if I will use this regimen for all my haplo patients, but definitely to consider in patients with mild or moderate renal insufficiency pre-transplant, or patient with high risk of renal complication who had renal issues during their chemotherapy before transplantation. Our next abstract is a large series. Comparison of transplant outcome in patient with ALL after haplo-transplant with PTCY or standard match unrelated donor transplantation. My main message from slide is our best shot to achieve reasonably good transplant outcome after allotransplantation in ALL is CR1. Beyond CR1, whatever you do, even with CAR-T, blinatumomab, inotuzumab, outcome is not that good. This is a registry study comparing outcome of PTCY-based haplotransplant, 487 patients, versus standard MUD patient, 974 patient in ALL. Little over half of the patients were in CR1. Almost three-fourths of patients received ablative regimen in both groups. Nearly 50% of haplo patients received bone marrow graft versus only 70% in MARD group. Overall survival, no different between the group. Similarly, relapse and non-relapse mortality, no different between haplo and MARD group. Nice overlapping curve. And now when author analyzed both ablative and RIC regimen separately, outcome remained no significant different in each group. This finding was confirmed in multivariate analysis, p-value non-significant, similar relapse rate in both groups, multivariate analysis for NRM, no different between the group. In summary, MUD or haplo uh, transplantation equally effective in patients with ALL. This remained true even when both ablative and RIC group analyzed separately. Our last abstract for today, but very important abstract. This is a BMT-CTN study presented as a late-breaking abstract on last day of the meeting. Phase 3 randomized trial of double cord blood transplant versus haplo-BMT for heme malignancy. I still believe cord blood transplantation is not gone yet. It is important that we continue to preserve our expertise. I mean, we should preserve our expertise in cord blood transplantation because cord blood transplant requires special clinical skill, which we used to have and looks like slipping away because we don't do anymore. There may be a need to consider cord blood product more frequently, as this product would have been collected and stored before the current COVID-19 infection. And cord blood units are always available immediately. We have one high-risk transplantation, adolescent, going to have a cord blood ablative TBI-based transplantation because of this situation. And also, I will refer you all to very nice editorial published few days ago in BMT by WBMT leadership. Title of editorial is Impact of COVID-19 on Provision of Donor Hematopoietic Cell Products Worldwide, Collateral Damage. Wonderful editorial. So back to this study. This is a phase 3 randomized trial. It was conducted in United States to better understand the relative efficacy of two donor types, cord blood and haplo-BMT, in adults with heme malignancy. Primary outcome was to compare 2-year progression-free survival between the treatment arm using intent to treat analysis. Commonly used RIC-BT and RIC-haplo-BMT regimen were used with standard GVHD prophylaxis. These are all both reduced intensities, most standard regimen used in the United States. Now, trial did not achieve its target accrual and was closed early. 186 patients were randomized to double cord blood and 182 to haplo-BMT group. Median follow-up, 2 years. 2-year progression for survival did not differ significantly between transplant arm. However, lower NRM and higher overall survival after haplo-BMT compared to double cord blood transplantation. You can see here significant p-value in NRM and overall survival in favor of haplo-BMT group. And you can see here nice separate curve with superiority of haplo-BMT over cord blood transplantation. I don't think I need to read this conclusion side. In short, lower NRM, higher overall survival favor haplo-BMT compared to double cord blood transplantation, but there are still indications to consider double cord blood transplantation. Friends, be safe. Continue to work to save lives. Our patient, our community needs us more than ever before. I thank you all for your patience. Complete presentation with slides will be available on IACH website in next few days, and I'll be happy to answer any question now. Please send your question via text messaging. So our next presentation, let me go over one more time. Our next session will be reviewing IEC, including CAR-T presentation and graft versus host disease. That will be part 2, TCT highlights. We'll send out the emails, date and time. So question is, do you recommend a full intensity conditioning whenever possible? Answer is absolutely yes. Now we do have a prospective data with a long-term follow-up, almost 4-year follow-up. It showed overall survival, relapse-free survival is superior in patients with AML and MDS. Hopefully this paper will be out soon. Initially, when we had this BMTCT and 0901 data published in JCO, but Scott Bark is the first author, published in 2017. There were many criticisms. This is a short follow-up. That's why we have a relapse-free survival superior, but no difference in overall survival. But now we have a long-term follow-up confirmed. So preferably ablative regimen in AML, MDS whenever possible. The next question is, do we need MAC for secondary AML or MPN? And again, answer is yes. AML we already reviewed. Now this study included AML and MDS, but same thing for AML if we are going to have a transplant indication. And you can see the first abstract, the best abstract we presented, MD Anderson, Dr. Popper, they used a fractionated busulfan, and the intensity was more than busi regimen, with excellent outcome in MPN and MDS, with 2-year survival in the range of 85 to 91%. The next question is, in Sirolimus study, did they comment on any adverse effect or average time to discontinuation? So I skipped that slide because of time constraint. So there were no major adverse events. Sirolimus handling was good, and it was continued up to the 6-month post-transplantation and tapered off. Average time to discontinuation. The next question is, TBI has long-term side effects. Should we avoid it? If my personal opinion, yes, we should avoid TBI whenever possible. In myeloid malignancy, there are no indication to me unless patient has a CNS involvement, and we still want to give TBI. Again, the role is questionable based on published limited retrospective data. Now, ALL patient, there are still indications to consider TBI based on published report. We are not there to quit TBI yet. But again, I agree with you, TBI should be avoided whenever possible in favor of chemotherapy-based ablative regimen. Next question is, do you recommend starting cyclosporine alone for new development of chronic GVHD without steroid? My personal opinion, no, I would prefer to have a steroid. Or best thing is, if you have a clinical trial, patient should go on a clinical trial. In our program, almost all patient acute GVHD, chronic GVHD goes on a clinical trial, multiple studies, easy to participate, and we don't get much GVHD nowadays. That's what I self-claim. But whenever we have, better to understand it by enrolling patient in a clinical trial. But if we don't have a clinical trial, steroid is still backbone of treatment. You can add calcineurin inhibitor if patient was already off calcineurin inhibitor. Next question is, where do you foresee myeloablative fractionated busulfan getting used in the future? Based on this publication, very impressive data. And if you look at the Fred Hush publication, MD Anderson, our program, we still consider busi in a young healthy patient in patient with myeloproliferative disorder. So my first choice in a fractionated will be MPD, MDS, or combined. That's where we are heading. And the outcome, look at the 2-year survival, 90+%, and no impact of age, patient younger than 60, older than 60, same good outcome, no difference. Older patient behave like younger patient. Next question is, do you recommend maintenance therapy uh, for um, bad risk AML? Yes, if patient is not on a clinical trial, almost all patient goes on a post-transplant preventive maintenance therapy at the same time tapering immunosuppression. And most of the time, myeloid malignancy goes on hypomethylating agent, FLT3 positive goes on a FLT3 inhibitor. And we have a very nice consensus manuscript recently published in Cancer for myeloid lymphoid malignancy, in Hematologica for myeloid malignancy led by Dr. Ali Bazarbachi. The next question is, Thomas, no. What is your preferred myeloablative conditioning for haplo donor transplant? So at our center, we do have a 2 ablative haplo regimen. One is chemotherapy based, which is high dose busulfan, 4 days, and TBI based, where we use ablative dose TBI. Less frequently used, but we do have a special indication for ALL for TBI based and chemotherapy based for acute myeloid leukemia. Both ablative regimen are very well tolerated, and to me, it is tolerated as good as reduced intensity haplo-transplant, if not better than reduced intensity haplo. Again, thank you very much. And if you have a more question, please do send me email or call me on my cell phone number. I'm always prompt in reply in email and cell phone too. Again, thank you very much, and we'll talk to you soon again for part 2 of TCT highlights on IEC and GVHD. Thank you again. Bye.